Hello everyone, welcome to today's video, and this is a continuation video of the part 1 of septic shock emergency in interactive oral examination. In our first video, we have discussed about some scenarios, its history, examination findings, investigations, diagnostics, and some relevant basics. Today, we are going to discuss about the management of septic shock, which will be guided by some main books and some guidelines. Everyone, I am Dr. Anuj. I am a general surgeon from Bangladesh. So let's get started. So everything to manage, we need to know the principle. And my principle here is according to the Survival by Sepsis guideline, and which states that the principle of managing a septic shock patient is to simultaneous resuscitation with management of infection with source control. And it should be goal directed. This is goal directed therapy that can come as a short note also. And what are the goals? The goals are in sepsis, central venous pressure is aimed at 8 to 12 units of mercury. Mean arterial pressure should be more than 65 millimeters of mercury. Central venous saturation, we have discussed previously, should be more than 70%. Hematocrit level should be more than 30%, and urine output should be more than 0.5 ml per kg per hour. So that are the goals, and this is the principle. And the Surviving Sepsis Campaign Bundle has updated in 2018, and it states that within 1 hour of a sepsis of a septic shock patient, we have to do these things. We have to measure his or her lactate level, and if it is more than 2 millimole per liter, then we have to measure it again. We have to obtain the blood cultures, and that should be prior to administration of antibiotics. And we should administer broad spectrum antibiotic empirically within 1 hour. And we have to begin rapid administration of crystalloid of 30 ml per kg or lactate more than 4 millimole per liter. If the patient is hypotensive or lactate is more than 4 millimole per liter, we have to administer fluid at the rate of 30 ml per kg. And within 1 hour, this update says that we have to apply vasopressor if the patient is hypotensive during or after resuscitation to maintain mean arterial pressure more than 65 millimeter of mercury. So keep everything in your mind. Okay, every point is very important, and every point will carry a mark. Okay, so that is the principle here. Now, in details. Resuscitation, very important. First of all, we have to assess the adequacy of airway and ventilation. That part will be described in another video. But first point is, as for trauma patient A, B, C, D, E, A for airway, here also we have to look for airway. Ask the patient whether he can talk or not, his sinuses level, everything. So I will discuss it in another video. Then for circulation, we have to create two wide bore and short, long, not long, short and wide bore catheter. 2. And we have to put in central venous line. And that central venous line will not be for infusing fluid actually initially. Because we have stated that the catheter should be short and wide bore. Central venous catheter has got a long channel. So that central venous line which we place at subclavian vein or interjugular vein, that is to monitor. And what to monitor? We have to monitor the fluid response. Okay. And the normal response, it is very important for your examination. Normal response is rise of 2 to 5 centimeter of mercury, yes, water. 2 to 5 centimeter of water, and which gradually drifts back to the original level over 10 to 20 minutes. If after infusing fluid there is no change, then that patient require more fluid to resuscitate. And if after infusing fluid there is large and sustained rise, then patient have high preload, so that patient is in the risk of developing volume overload in the form of pulmonary edema or cardiac insufficiency. So that central venous pressure, though in our context, in our tertiary center level, even we cannot afford this thing. But that is ideal that a patient is shocked must have a central venous line for monitoring. Clear? Now, dynamic fluid response. And guideline says that within 1 hour, 30 ml per kg if the patient is hypotensive or lactate is more than 4 ml per liter. Now, how to give the fluid? This is called dynamic fluid response in any kind of shock. Okay, shock is of many types. That may be distributed shock, hypovolemic shock, cardiogenic shock, lots of endocrine shock. A patient when comes and he becomes unconscious or something, we don't know what is the reason of the shock. So in every shock, every kind of shock, we start with the dynamic fluid response. Okay, what is dynamic fluid response? That again, 2 wide bore cannula, and we will infuse 250 to 500 ml fluid within 10 to 20 minutes. That is running drips. So 250 to 500 ml fluid within 10 to 20 minutes. Then we monitor by measuring the blood pressure, heart rate, urine output, that's it. Okay. Then we will infuse again another 250 to 500 ml fluid within 50 to 10 to 20 minutes. Then we will measure again that pulse, blood pressure, urine output, whether there is change or not. If that patient has got changes, improvement, that patient, he is responding. It is called responder. Okay, if that patient's response, there is progressiveness. Okay, tachycardia decreases, blood pressure increases, but not up to the mark. Then it is transient responder. And if that patient has got no response, that is non-responder. And we categorize that patients, and according to that category, we manage this patient. So there is dynamic fluid response. That can be a form of a question. You can get a question on that dynamic fluid response. Okay, so that is the basis. And type of fluid. Actually, there is no ideal resuscitation fluid. No ideal resuscitation fluid. And in case of resuscitation, one principle you have to maintain, that is, you have to replace what is lost. Like if blood is lost, you have to replace it by blood, not by fluid. Okay, if sodium is lost, you have to replace by sodium, not by fluid. So what resuscitation means, it should be replaced by what is lost. And that's why till now we are in search of an ideal resuscitation fluid, but till now we cannot find that out. So there is controversy and there is debate that what should be an ideal, what should give in crystalloid or colloid, and studies have found that there is no advantage of colloid over crystalloid. Rather, colloids are costly. So the cost benefit ratio, it doesn't work with colloid. That's why crystalloid is better, or crystal is advised due to availability and low price in the resuscitation. And ideally, you guys all know the Ringer's lactate or Hartmann solution, there's a use. And obviously, that should be used in euvolumic or isotonic. Okay, we have to avoid any kind of hypotonic fluid in shock. We can use hypertonic fluid or isotonic fluid, better to isotonic fluid, but never hypertonic fluid. So this is the type of fluid, and it can also come in a short note. You discuss use of fluid, okay, or compare crystalloid and colloid in dissertation. So mind it, everything can come as a question. And another point is avoid. We are used to give this hydroxyethyl starch when you find any patient is in shock and blood is not available or something. We think that will increase his pressure, but in case of septic shock, don't use it. Studies showed that it has deleterious effect on septic shock patient. And also even this sepsis, there is loss of plasma actually, and we can give albumin, but it should be given a septic shock patient and who needs substantial amount of crystal, not initially, because this is costly. And again, I have told that there is no that much uh, cost benefit ratio in using colloid. So better to give for Hartmann solution or Ringer's lactate, even normal saline. But normal saline, I think there is a saying that normal saline is not normal because it causes hyperchloremic metabolic acidosis. Okay, then we will got the second question that we will control our infection. As it is sepsis. Sepsis, that means septic shock means it is caused by gram-negative or gram-positive toxin. So we have to start an antimicrobial, and we have to start it within 1 hour, and also we have to send the blood culture first. Okay, blood culture first, and how to send blood culture? Actually, we need to send 2 times from 2 things. One is from percutaneous, one sample is taken from percutaneous link, and another is from any vascular access like central venous line or even IV cannula. So one is taken from that thing and one is taken percutaneously. Okay, so the blood culture is sent. Then IV antimicrobials is preferable here, and empiric therapy. You guys all know there is many things written in there, rationally as antibiotic and empiric therapy. That means it is started, antibiotics started prior to culture sensitivity report. That is empiric therapy. In empiric therapy, Rajukio. Empire from empire it has come, Rajukio. So in empiric therapy, we will try to assume that what microorganisms can cause the disease, and we will use all our resources to kill all organisms. So our target will be all organisms, responsible organisms, suspected. And in case of when we will get the culture sensitivity report, then we will kill that specifically. That E. coli is responsible for that, and that antibiotic is sensitive. Then more specific, but empiric that it means I will target everything. Okay, here is I will target all microorganisms in one hand. I think that everything I will target. So I will target gram positive aerobes, gram negative aerobes, also anaerobes. So mainly these things. You guys all know gram positive aerobes, gram negative aerobes, and anaerobes. So ceftriaxone, then gentamicin, okay, metronidazole, everything is used in conjunction. But keep in mind that where is the site of the lesion may be and what microorganisms can cause the disease. So this is empiric therapy. And There is study says that this empiric therapy, if you start, we can start within 1 hour, that will decrease the mortality rate. And also, we have started empiric therapy. Then we have to regularly assess the outcome of empiric therapy. Regularly assess the outcome of empiric therapy. And this regular assessment is done by complete blood count. And if we find that neutropenia there, then we will have to advise procalcitonin, that is written in a guideline. Procalcitonin or other biomarkers like ESR, CRP, everything. Procalcitonin. And if this procalcitonin level is significant, then we have to need the antimicrobial. This we have to need to change the empiric therapy. And again, we have to start the combination therapy, and that will be against multi-drug resistant Acinetobacter and Pseudomonas. So that are the points which are written in the surviving sepsis guideline. So remember these things. And empiric therapy should not be administered for more than 3 to 5 days. That should be less than 3 to 5 days. Because if we use that broad spectrum antibiotic for long, that means we are killing many organisms. Because our target was that we have to kill everything. And if we kill everything, then there will be the development of resistant organisms. If we wanted to, we have to kill everything, then there will be development of resistant organisms. Even there will be growth, fungal growth. That fungus will overgrow. And you guys all know that there will be antibiotic acid colitis caused by Clostridium difficile. So that empiric therapy you have to stop within 3 to 5 days, not more than that things. Okay, and within that thing, the culture sensitive report will be available, and we will treat accordingly according to the culture sensitive report. And we have to control the source. Okay, in our first scenario, there was a wound infection, so we have to control the infection. Sepsis, control of sepsis, control the infection. Okay, if and the second question, there was an foreigners gangrene, so we have to surgically debride or surgically excise that thing. So debridement, that means we have to excise or we have to remove all dead and devitalized tissue. All dead thing is removed, that is called debridement. And if we excise a normal healthy tissue along with the dead and devitalized tissue, that is called excision. So surgical debridement and surgical excision. Excision, that we will remove some healthy part also, and debridement, we will remove that dead and devitalized tissue only. So in second cases, we have done this. In first cases, we have controlled the source of infection by dressing or something. And if that patient doesn't improve, then we have to look for IV channel, because that can be a source of infection. And if it is a source of infection, then remove the IV channel, but re-establish a new line. Okay, so these are the things. Now, our important these things, we have to know the use of vasopressor and inotropes. Because in septic shock, there is peripheral vasodilation. So vasopressor, that means vasoconstrictor. So if you use that drugs, that will cause vasoconstriction, and that may help in survival of the patient. So according to guideline, the first choice is noradrenaline. You guys all know the phenylephrine, epinephrine, norepinephrine, vasopressin. These are the vasopressors. So according among them, noradrenaline is the first choice, and vasopressin or epinephrine are second choice. Okay, so noradrenaline is the first choice. Okay, and timing. There is a controversy actually, because the guidelines says that if that patient is not maintaining the mean arterial pressure of more than 65 mm of mercury, then you have to start early. Now recent guidelines say that you have to start early start. But previously, or even in our main books, it is written that at first we have to correct the hypovolemia of the patient. We have to resuscitate the patient with the fluid, adequate fluid. At first, we have to give adequate fluid. After that, then we have to start this. My teacher used to say that don't beat the tired horse. That means if a horse is very tired, eh, and if you bite, if you beat that horse to run fast, then after some times that horse will fall down. That horse will slip down. Okay, so don't beat the tired horse. It is applicable for another case in AKI, acute kidney injury. Okay, in acute kidney injury, if you give, if you ask our kidneys to excrete urine by infusing diuretics, but if you don't give that kidney enough fluid, then after some time the kidney will fail. Okay, so before giving Lasix, you have to maintain the hydration of the patient. So give fluid first, then Lasix. Even in that particular case also, correct the patient's hypovolemia, then give the vasopressors or inotropes. But recent guidelines says that within 1 hour, if you want to give, that has a good prognosis. Okay, so it's controversy actually. Now, the theoretical thing is that how does this vasopressors work? I have stated that there's peripheral vasodilation, that vasopressors work on sympathetic nervous system and causes vasoconstriction. Okay, now how does norepinephrine work? Actually, these are adrenergic nervous system, and there is alpha 1, beta 1, alpha and beta, alpha 1, alpha 2, beta 1, beta 2. But for more importantly, you guys to need to know that the noradrenaline has the predominant alpha activity. It's really alpha 1, and that alpha 1 is a vasoconstrictor. Okay, and beta 1 is mainly cardiac, beta 2 vasodilation. So that's why that noradrenaline actually causes vasoconstriction and increase peripheral resistance. That's why increases blood pressure also. And if I want to go details, because I think that should be taken, that in low dose, that low dose is important. Low dose that are predominantly renal. There is increased renal, cerebral, coronary, mesenteric blood flow. Every blood flow is increased with vasodilation because of agonistic action on dopamine receptor in the vascular bed. Keep that. In low dose, that doesn't cause vasoconstriction. It causes vasodilation actually due to dopamine receptor activity. So in low dose, it will not work. Intermediate dose, that is predominantly cardiac, and that will be cause beta 1 activity, that will increase the heart rate. And high dose, that is vasoconstrictive. Dose that is 10 to 20 microgram per kg per minute, that is vasoconstrictive and as well as cardiac. And that will cause marked vasoconstriction and a rise in blood pressure. But that vasoconstriction, it will also cause vasoconstriction of the renal vessels, mesenteric vessels. So the kidney perfusion, renal perfusion will be decreased. That patient may develop oliguria, and also mesenteric vasoconstriction, mesenteric blood supply may occur, mesenteric ischemia that may occur. So it is so that should be curtailed. Not that I am infusing, giving noradrenaline, patient is not responding to noradrenaline, but I am giving noradrenaline for days or days. That will deteriorate the patient. So that should be curtailed or that should be stopped. It's minded. And at very high dose, there is overriding adrenergic activity, cause extreme vasoconstriction, and that will cause renal, that is suppress renal vasodilation, as well as that is affect deleteriously the renal and peripheral circulation. So very high dose is also very bad, and high dose for long days is very bad. Low dose will not produce any vasoconstriction. High dose will produce vasoconstriction, but that should be for few hours or few days only. Okay, I think that is okay. Now, what is the difference between epinephrine and norepinephrine? Okay, epinephrine mainly beta agonist, beta 2 actually vasodilation করে. Norepinephrine is alpha agonist, I have stated, and that alpha agonist causes vasoconstriction, and beta 1 raises heart rate. With this thing, they work. Now, inotrope. According to the guideline, that says that if the patient is is not responding well, or if that patient has got some myocardial dysfunction, suspected case of that thing, then you have to start the inotropes. And in case of inotropes, actually, dobutamine is stated in the guideline, not dopamine. Dobutamine. A trial of dobutamine is given up to 20 microgram per kg per minute. Clear? Dobutamine. And how does it work? It increases intracellular calcium concentration. That's why it increases myocardial contractility and increases cardiac output. Inotropes means force of contraction. Clear? And dopamine is usually not used here, not recommended here, though we use here in Bangladesh dopamine very much. Dopamine is used only in highly selected cases. Patients with low risk of tachyarrhythmia and absolute or relative bradycardia. There are indications of using dopamine. And I have told you previously that we have to terminate. Okay. So what are the indication of termination of vasopressor inotropes? That is reduction of urine flow. That means that patient is developing renal hypertension, tachycardia. Okay, that that beta 1 activity is acting, it is cause increase heart rate and development of arrhythmia. These are the indication of termination of isotrope, inotrope, or vasopressin. Other supportive therapies according to the guideline are blood product administration. Like if the patient is hemoglobin concentration is less than 7 gram per dl, then we have to give blood product. There is no use of erythropoietin or fresh fusion plasma or antithrombin in particularly in that case. And prophylactic platelet administration is advised. And that is advised if that level is less than 10,000 per millimeter of cube. If that patient is having significant risk of bleeding, then that will be less than 20,000 per millimeter of cube. So this is the one thing. Controversy is corticosteroid use. Some say that in sepsis, there is adrenal insufficiency or glucocorticoid receptor resistance. That's why you have to use corticosteroid. But study findings are not according to the knowledge. Actually, practical and theory differs. Okay. So, if corticosteroid is used, it should be only be used if above therapies fails to restore hemodynamic stability, and only IV hydrocortisone 200 milligram per day that is written in the guideline. So it is corticosteroid. Now ventilation, ventilation, that means aim is to limit tidal volume to 6 ml per kg and give high PEEP. That question will be asked. That is, tidal volume is low, 6 ml per kg, and PEEP, high PEEP. Okay, prone ventilation and permissive hypercapnia. That discussion will be, I will discuss it on next video on ARDS. Okay, I will discuss in details there. Why prone ventilation, why high PEEP. Okay, so I am skipping the thing. Then another thing is glucose control. Our target is to keep that under 180 milligram per dl. And if glucose levels are not up to the mark, then we have to monitor that blood glucose level 1 to 2 hourly. And then we have to monitor 4 hourly. Renal replacement therapy, and there are some few indications I will discuss in another video. And bicarbonate therapy is not indicated. DBT prophylaxis, deep vein thrombosis prophylaxis is very important here, and low molecular weight therapy plus intermittent pneumatic compression devices are used, advised here. And if patient have severe coagulopathy, then they no low molecular heparin, stockings or compression device only. So DBT prophylaxis is important here. Glucose control less than 180 milligram per day. These are points. You have to give IV PPI, proton pump inhibitor for stress ulcer prophylaxis. And nutrition, if this patient can tolerate oral, then it is better. If not, then you can give it by enteral, NG tube or other tubes. Parenteral oral or enteral therapy is better than parenteral therapy. And initially, you need not to give that much fluid or calories. Low dose feeding up to 500 calories per day in first week. So in first week, low dose feeding is advised or is told or stated in guideline. Now another point is prognosis complication. You guys all know. Then individual awareness 50 to 60%, but sepsis, if it is associated sepsis, then the mortality goes to 90%. So mortality may be 90% if sepsis is associated with ARDS. Okay, that is the thing. That there are lots of options, but mortality is very high. Complications. Complications may be related to the disease or wound. Actually, in that particular first case, there is wound. So wound related, that means wound infection, wound dehiscence, burst abdomen. There are lots of options. Even the sepsis also, the pelvic abscess, then subhepatic abscess, it can occur. Or in case of second case, so the skin gets slapped out, necrosis, even that may increase, extend up to the abdominal wall. So these are the related to the disease or wound. Another thing is related to the infection, state of the sepsis, septic shock, sepsis, then septic shock. There was previously there was a bacteremia. I just explained this bacteremia. Then there is SARS, SARS. Then there is sepsis. Okay. Previously, there was severe sepsis, but in recent guidelines, that severe sepsis is excluded. After sepsis, there is septic shock. After septic shock, the patient will develop multi-organ dysfunction syndrome, then multi-organ failure, and there will be death. So, mind that things. Now, adverse drug reaction. The drugs actually there is noradrenaline, dopamine, that things. So you guys all know dopamine and noradrenaline causes vasoconstriction. So there will be decreased end organ dysfunction. Ultimately, that can lead to kidney hypertension. That means oliguria AKI. Okay, and that also retain sodium and increases heart rate. And in case of dopamine in low dose, that is very good for the widespread vasodilation. But in high doses, that will raise the blood pressure due to vasoconstriction. But it also, I have stated previously, that it also lead to renal vasoconstriction. So that patient is more prone to develop acute kidney injury. So keep dopamine dose as low as possible. Clear? So there are some terms, the inotropes, that means increase force of conduction, chronotrope, the drugs that increases heart rate, dromotrope, that increases conduction velocity, and badmotrope, that means that increases excitability. So another next question is about the outcome assessment. And you guys all know in sepsis there is SOFA, that means sequential organ failure assessment, or QSOFA, that means quick SOFA. That QSOFA I have described in previous part 1, okay, in diagnosis chapter. So SOFA score, there are lots of things, dysfunction score, 0, 1, 2, 3, 4, respiration, then coagulation, then hepatic, then cardiovascular, then neurogenic or CNS, then renal. So there are the point, if you can remember, then that is very good. And if you cannot, then the QSOFA is essential. GCS, respiratory rate, blood pressure, systolic blood pressure, the 3 component was there. You have to maintain, you have to mention it everywhere. Okay. And there is another question is end point of resuscitation. You guys, I think you guys now all know that base deficits, lactate, and mixed venous oxygen saturation. This is the end point of resuscitation. Okay. So that is very, outcome assessment is very important. So these points you need to know. Newer therapies, a question may come to what new therapies are there for septic shock imaging. So these many names are there. Immune modulation strategies like anti-endotoxin antibodies, anti-cytokine antibodies, cytokine receptor antagonist, immune enhancer, nitric oxide synthase inhibitor, oxygen radical scavengers. There are lots of options, but matter of fact is that most have failed to demonstrate efficacy. So most of have failed to demonstrate efficacy. So their things are very costly but not effective. So we don't need to think about this. But in question that may come and the teacher may ask. So there, I think I have described everything. That why patient has metabolic acidosis, how AKI develops in ischemic pulmonary syndrome, compare colloid crystal in resection of shock, discuss use of inotropes in shock. I think I have discussed everything. So that question may come in your short answer question also. So I think I'm done with septic shock actually. Septic shock is a very vast chapter, very vast topic. I have just discussed only a few things. My next lecture, I will try to discuss on more topics. Like next lecture, I will try to discuss on acute respiratory distress syndrome. Okay, I try to discuss some scenarios. Then I'll go for the management, and in that topic, I will try to discuss on the ICU. I'll try to discuss on the ICU management. Okay, CPAP, BiPAP, PEEP, okay, CMB mode, SMB mode. So I think you guys are invited to attend my next video. So please subscribe my channel and wish me luck for better. Thank you very much for watching. Thank you.